Good afternoon, everybody. Today is November 2nd, 2021. And today's SEVA VentRounds is called Back to Basics. And I think it will become very self-explanatory as we go through it. There's some really cool waveforms for today. We have 3 cases, and we'll go over them in detail with all of you. Thank you. So just the disclosures, we discuss particulars of ventilator modes. There is no endorsement of any particular mode, manufacturer or company. Whatever we say, it's our opinion. It's mine or Rob Chatburn's. And I mean, it does not represent the Cleveland Clinic. Here are my disclosures as well as Rob's for when he logs into with us. Some ground rules. This is a recorded session, so keep your microphone muted, please. And I may call you to comment, or if you put a comment in the chat that we need to discuss amongst ourselves, I'll call upon you to tell us what you're thinking and just discuss all together. There's a lot of learning that occurs. Every single one of these that we have done, I learned something. For the Cleveland Clinic employees, there's a CME at the end, and there's a QR code. You just scan it with your phone, and you will be able to see what you need and connect. All right. So let's get started. I have 3 waveforms. Any of the fellows wants to give it a shot to this one? Actually, this is hot off the press. I took this picture today in the morning. Any of the fellows wants to give it a shot?
I can volunteer.
All right. Thank you, Steve. All right, Steve. This is, and I put the whole screen for you so that there would be no, you're hiding stuff from me. So here you go. This is all yours.
Okay. Well, so all the breaths are patient triggered, and I think they're probably all ventilator cycled, which I can tell because of the fact that it says volume control at the top and the fact that there's an eye time set. Otherwise, I might have to struggle a little bit more. But anyway, so that makes it VCCMVS. I also was trying to think, in theory, it could be PCCMVS because it's not like a totally perfect flow waveform, but again, it says volume control at the top, so that helps me. And the flow waveform is is reasonably the same throughout. And this ventilator, I think in particular, can have that sort of not perfect flow waveform. So anyway, we have VCCMVS. What's the load? So this one's a little bit tricky. Because a few reasons. I guess one is that on the expiration, it doesn't go back to baseline. So then the question is, do you have expiratory work or is it air trapping? It's not completing the exhalation. So I guess then we'll try to think about how we would figure that out. If we look at the pressure waveform, it also has this downward deflection in the middle and the upward deflection at the end. So in terms of trying to figure out why that would be, if the patient is making some inspiratory effort, then it would, downwardly deflect the middle of the pressure waveform. So that's probably why. And then, maybe beginning to stop the inspiratory effort toward the end of the inspiration. So anyway, but then how does that get back? That shows that there's some inspiratory work, and there's probably some expiratory work too. And it's not work shifting, but it's, it may be a little bit of work shifting, but not flow starvation. So anyway, moral of the story, PMOS is there. And I guess elastic versus resistive, maybe there may be a hint of resistive, but it's hard to tell. So we'll go with PMOS as the answer. NEPV discordance. So the trigger is they're all patient trigger. So, and let's see, the trigger at 1.6 liters per minute. I don't see any reason that the trigger would not be anything other than normal. In terms of inspiration, as I mentioned, I think there's a hint of work shifting. As far as cycle goes, let's see here. Okay, so the pressure waveform does deflect upward a little bit at the end. In terms of if we'd be better off with a shorter eye time or a longer eye time, we might be a little bit better off with a shorter eye time, because then that would enable us to give a little more flow earlier, which would reduce the work shifting. So I'm going to go with a little bit of a late cycle, but I don't think it's too bad. And then expiration, like I said, I think there probably is a little bit of expiratory work. And, the waveform is in that really nice shape. And, we definitely have inspiratory work. We probably have expiratory work too.
Thank you, Steve. If you had to, assuming that the goal of this patient on mechanical ventilation is safety, would you change anything on this ventilator?
Well, so the tidal volume is set at 500. So, I guess one question would be how many cc's per kg predicted is that? And then I guess the other thing would be, let's see, respiratory rate set at 18, but the patient's breathing at 35 with FiO2 of 100 and PEEP of 8. So it's a weird FiO2 PEEP combination for one thing. If it's like an ARDS patient with a goal of safety, we probably try going up on the PEEP, and obviously we shouldn't leave it at 100% FiO2 for, a prolonged period. So that would be the one thing. It's a little bit weird to me too, just to have, if the patient has goal of safety, to be letting them breathe at 35 when the respiratory rate's set at 18. We might want to slow the rate a little bit. And I guess this is a controversial topic in terms of rate-related lung injury and these types of things. But yeah, I think the starting point would be go up on the PEEP.
Really, thank you very much, Steve, for your comments. Really useful. This patient in particular has a PFO, and on top of that has COVID. So they're battling issues at the same time as we were walking by. They were trying to wake him up. So I took the picture because it has several features from volume control. So you can see it's volume control, CMBS. I agree with you that all the breaths are triggered by the patients, but they're cycled by the machine as you recognize. There's the eye time, and all of them have the same inspiratory time. At the first time that I saw this, I thought that I was dealing with the dual control from the servo eye, but this is set up. So you see down here this flow pattern, this little circle down here. The servo eye has this behavior in which you can set up your flow waveform either as a square, in which then the flow pattern, you just put 100. I mean, it goes all the way to 100, and then you start going all the way down in percent. So it starts at the 100 is the percent of the peak flow. So if you put 100, it would be a square waveform, and then if you go to 50%, it would look like this. Well, more like that. And then if you go to 0, it would be a descending ramp all the way like that. So this is what you would be expecting to see in this waveform. Sorry, it would be a straight line. If I stop sabotaging my existence with, there you go, a straight line, and you're not seeing that. And this is something that we found out is whenever there is this little circle here, that's the tube compensation and or circuit compensation. And circuit compensation, the ventilator actually creates a simulated waveform of what it would expect the flow at the ET tube to look. But if you turn it off, it actually shows you that the machine is delivering a a descending ramp flow, and this is actually a simulated waveform, not what you think. It doesn't look like this, because if not, it would not be volume control. So that's why I call this back to the basics, because in volume control you have to control the waveform completely. But when you are on this ventilator, it uses this thing, and the algorithm changes the waveform to look like that. Rob, any comments on that?
Yeah, I wish I understood what the algorithm was doing, because it doesn't make any sense to me.
Yeah, and we didn't know.
Ivor, can I ask a quick question on that?
Oh yeah, Ivor, welcome to VentRounds. This is awesome.
Oh,
Please
no,
go
it's an
ahead.
honor. Thank you. Could you just then clarify, is your TI flow rate uncoupled from the flow pattern here? You know, intuitively, those two should be electrically linked through the algorithm, but it appears they're uncoupled.
Right. So so the first time that we saw this, Ivor, we thought that this was fake volume control, because definitely the eye time and the flow pattern should match, right? They should be identical on how they look. And what it turns out is when we met with the engineers for an unrelated issue, we asked them about this, why did the flow waveform change? And their answer was that this actually was not the actual waveform. It's a simulated waveform based on what they think, based on the PMOS that it's acting on, how it would look with their at the trachea level, which, as Rob said, didn't make much sense to us, but it's a visual sabotage for us every time we see it, because we expect it to be coupled, if that makes sense. So perfect, Steve. You caught this very well. The drop in pressure over here. Actually, if we wanted this to look, or how it would look if there was no PMOS, this would look essentially like that. And the presence of PMOS through the breath, it gives you this drop in the pressure from the ventilator, because the PMOS is essentially pulling while the ventilator is pushing. So you get that. And I think that you also read this very well. Instead of having the nice exponential decay, you have this thickened waveform, or that it's moving away from the baseline, that suggests that this patient is activating the expiratory muscles during expiration. Rob or Ivor, since we have the two masters on the line.
Nothing to add to that.
Yeah.
Except that, again, this is the pattern where people could look at it quickly and say, well, there's gas trapping because we didn't reach zero flow, but not necessarily so, right?
Right. So that's and let's touch base on that on actually when we get too deep. But you thought that you're absolutely right. And on this pattern in which there's a transition from expiration, active exhalation, to active inspiration, there's going to be a rapid change in flow. And although there could be auto PEEP, this is not the way to detect it. You will not be able to detect it under these circumstances because of the transition.
Eduardo, just an observation, and this is going to sound very old-fashioned. It really reiterates the importance of integrating a simple clinical assessment with the flow pattern here. There's that beautiful old J.P. Crest paper where they evaluated just putting the hand below the sternum. And I really cannot emphasize that if you're trying to detect particularly expiratory PMOS, that is literally the most helpful way to correlate. So while the waveform analysis is correct, it's the correlation with both the inspiratory and expiratory PMOS that can be detected at the bedside, but even without a balloon, that's going to enhance this analysis.
I second and triple that. Absolutely, Ivor. If you don't put the hand on the patient, it's a big. You're missing a large amount of information. In terms of trigger, I think the trigger is normal. There is no major deflection on the pressure. As you pointed out, Steve, the trigger is set at 1.6 liters, and actually it's following really nicely. It pressurizes rapidly. There's no major abnormality there. In terms of inspiration, there is work shifting, as you highlighted, but the work shifting is not, it exists, but it's not severe. The pressure is not going below baseline, so the ventilator is giving more flow than the patient is asking for. In terms of the cycle, I do think that, for example, this one over here, as you pointed out, there may be the muscles have relaxed and they're going actually to expiration, and that's what we are seeing here, this rise. So there may be some amount of late cycle, although I think that whoever the RT was setting this, they did probably a pretty good good job setting that eye time. And finally, the expiratory work. Now, there is a question that came out, which is, why is the tidal volume higher? So that comes from Satish Chandra. So, Rob, you just finished some work with Ping relating to the tube compensation algorithm on the servo or the circuit compensation. Do you want to comment on it?
That's not going to help because we found that that doesn't answer this question, right? The problem, there was unexpected tidal volumes with pressure control with adaptive targeting, not this situation. So I think what people are seeing is that, if I can read that correctly, it says exhaled tidal volume 540. That's because you can't see the inhaled tidal volume, it's cut off. So let's assume that the inhaled tidal volume was 500. How are you going to get 540 for an exhaled tidal volume? Well, the answer is, again, what we were discussing. This patient is actively exhaling. He's not going to necessarily exhale exactly as much as he inhaled, which means that his FRC is changing every single breath.
Very good. So the point being is that because he's exhaling, he may be exhaling more than what he inhaled. Is that what you're saying?
You can't do that forever, obviously, he'd collapse, but for one breath he can.
So there's a couple of other comments. One from Mohammed says the pressure waveform, it doesn't go back to PEEP. That's correct. And by looking at the pressure scalar, can we say that the patient has high resistance? I have trouble doing that, Mohammed, when there is PMOS, because it could be that the patient has high resistance, or it could be just that the patient is doing active effort through the expiratory phase of, I mean, he's switching from inspiration to exhalation. So this may be the changes in the pressure and in the flow may be just active PMOS. And so sometimes in patients like this, either if you really want to know the physiology and it's important for the management of them, doing things like giving them a bolus of propofol or sedatives, or even a dose of paralytics in some of them, to be able to read them. But I really have, I've been caught misreading this as increased resistance, only to be the moment that you sedate the patient, they disappear. And that goes with what Dr. Douglas is mentioning of putting the hand on the patient and seeing the active exhalation. Any other comments from the team or any other questions? All right. Well, good job, Steve. This was a really good case of work shifting, and we had the chance to talk a little bit about this particular on the ventilator in which the flow waveform doesn't look like it should be. All righty, let's see the next one. This one actually was a courtesy of Satish. He sent this to me on a tweet message, and I glanced at it, and it created a little bit of anxiety. So I put it here for the team to analyze, so that we can go back to the basics on this. So any fellow wants to give it a chance, give it a trial? Have no fear. Patrick, you want to try it? I'm in a cafe. Okay, not Patrick. Ahmed, are you in with Patrick?
No, I'm not. I can give it a try, I guess. Let's see. So, I mean, the obvious first thing that I'm gonna try and forget about for a while is the very high frequency kind of vibrations and the waveforms. But I'm gonna try and go with the basics. So the pressure waveform, if I kind of neglect that, would look more like a square waveform. So I'm gonna go with a PC for my control variable. The inspiratory time is very variable between the breath, so I'm inclined to say that this is some form of as a CSV. I don't see indications of patient triggers though, which makes me wonder. But I mean, I mean, at least the breath are cycled by the patient because they are of variable length, which would be pretty unusual for a CMV mode to be like machine triggered and patient cycled. But so I'm gonna go with CSV and assume that they are patient triggered, but I just can't see the evidence of the trigger. And then I'm gonna go with set point, assuming that the pressure is set at a certain value. Now, in terms of the load, looking at the expiratory waveform, there's a very rapid depressurization, and then I mean, looking at the flow, it like bounces pretty quick, and then it takes a while to come back to the baseline. So I'm inclined to say resistive is the load. And then I'm gonna say in inspiration, it might be PMUS, just because the flow isn't fully decelerating. Now there's these oscillations again, but the second thing is the peak expiratory flow is different between all breath, which makes me wonder if there's some PMUS during inspiration and it bleeds into expiration, and that's why we have some difference in the peak expiratory flow. Now, after I do all that, I look at the at the data actually on the vent down there, and I see that there's a tidal volume setup, which makes me wonder if that is the case, then who knows? Maybe it's a PC CSVA, but I'm not convinced this is a classic volume control looking at the flow waveform. Now, trigger, I'm going to say normal. I can't really, again, see a lot of evidence for the trigger, honestly. Maybe it's a flow trigger, maybe it's so sensitive, but and I'm not familiar with the ventilator. Inspiration, if I said PMUS, then maybe minimal work shifting, but I don't see a lot in the pressure waveform. Cycle, I'm gonna again say maybe normal or early if we consider. I would go with normal, and then expiration I would go with normal again. Now the oscillations, they look very weird. They are not our classic like secretions. They are definitely not heartbeats because the frequency is so high. And they are not there all the time. They are only there when the flow is there, which makes me wonder if it's something vibrating within the circuit. So I'm gonna go with secretions, although it's not very classic for that appearance. All right, now this is my fictional read. Tell me the truth.
Thank you very much, Ahmed. This one trumps a lot of items. So let's go in order because I agree with you. So back to basics. So this is one of those situations in which the mode reads volume control ventilation, right? And if the mode reads volume control ventilation, you're supposed to be controlling the flow. And so I would expect either a square waveform or a descending ramp or a sinusoidal, or you name it, but there should be a geometric form here. And instead of that, you don't see that. You see the pressure rises and it reaches a peak, and then it kind of goes down and it starts oscillating up and down, and then it ends and it goes down again with a high peak, and then, as you mentioned, this pattern that looks like a high resistance. And so, and I agree with you. Up here, it looks like pressure control. I think one of the clues when I was looking at this is that they have this button down here, or this variable that says Pmax. And you may note that the at the level of where this is stopping is probably around the 35 mark for the peak pressure. So I presume that what we're dealing with is some sort of a dual targeting system in which it's the Pmax, and it changes from pressure, from flow to a pressure controller once that you have reached that peak pressure, which we know that Draeger does that. And I will ask Rob, I mean, I think this is an Engstrom ventilator. I'm not entirely sure what, and probably Satish can let us know. I see him on the line. And then we have these short breaths so you have these two that seem to be of a set rate or a set inspiratory time. And then it changes to these smaller breaths that would change to I don't know what's cycling the breath right here. So Rob, I don't know if what are your thoughts when you see this? And it turns out then the tidal volume is super petite. So I don't know if this is a little baby and the amount of variation that we're seeing on the monitor is just it's the sensitivity of or the gain on the screen. It's too sensitive. I don't know, Rob. Can you?
I don't recognize the ventilator. I think somebody made it in their basement.
Yeah, no, it says Engstrom. It is an Engstrom. Thank you, Satish.
Engstrom, but Engstrom is no longer marketed. That's a very old brand name of ventilator. It was what GE used to be.
Okay.
So God only knows how old this ventilator is, but Engstrom is no longer marketed in the United States. And I don't recognize the screen, and I think you're probably right that the oscillation is a very poor pressure control, like a chattering pop-off valve, like a mechanical pop-off valve. Because it looks like, like bubble CPAP, right?
Yeah, I saw that Ivor thought that this could be an ultrasonic or a nerve attached or
No.
that is vibrating through but it should do the same during expiration as well as any of the other oscillations. So I don't know if what we're seeing is that it's just trying to maintain the pressure, and every time the pressure goes down, the flow goes up, trying to get back into flow control, and then it shuts down because it's reaching the peak pressure, and it keeps shutting up until the I time is done. That's
definitely not good.
Yeah.
And I don't know what makes the short breaths, like you said. What's the cycle variable there?
I have no idea. This doesn't.
We tell by looking at it.
And I mean, look at the compliance and the resistance of this. I mean, the compliance is 3.8, and the resistance is, according to this device, 71. And I do agree with you.
Possibly be measuring it with a signal like that.
Exactly. But I do think that the resistance is elevated. I mean, this makes me think about that.
Mm-hmm.
But there's no volume being delivered here. So Satish, I don't know if you can unmute yourself and let us give us some clarity on what the heck was happening with this ventilator, or were you trying to trick us into something? Satish, can you unmute yourself? Sorry, I couldn't speak. Okay, that's fair. All right, well, that's what I would say. So Satish, is it attached to a little baby or neonate? I think that the trigger seems to be set by the rate of the ventilator. That I can say. The inspiration, I don't know if I don't see any PMOS here, my dear Ahmed Gohar. And the cycle, I'm unclear on the cycle on this machine. It seems that something else is cycling this breath, and it's unclear to me. I mean, it's supposed to be getting 425, and it's only getting 98 of tidal volume. So that could not be a baby. That doesn't make any sense. So it's either this is obstructed or very severe resistance on the patient. So there's a question here. Does that vent have a floating exhalation valve? Do you know, Rob?
Like I said, I'm not sure what ventilator that is.
Yeah, I think it's an Engstrom. Satish told us. So it's
yeah, but that doesn't tell us anything. Like I said, Engstrom
mm-hmm.
is an ancient name. It's been around for many decades.
Okay.
And it's not, as far as I know, there's no ventilator marketed called an angstrom anymore.
Okay. So what we would say is this definitely is not it is not volume control anymore. If it started as volume control and then it has variable size of breath, I would say that's probably an IMB, and based on the Pmax, this is probably a dual setting, meaning it changes from volume control to pressure control based with that. Do you disagree with that, Rob?
I can't say. That's just so bizarre that there's no way to interpret what's going on.
Well, that's what I can see, because this is not volume control. Would you agree?
Yeah, it's no control. That thing is out of whack, completely out of whack.
And then work shifting. So the question is these oscillations that are high frequency. And actually, Satish, I would say that you sent me several images and in very different modes, and all of them had these very high frequency oscillations. So it makes me suspect that there may be something wrong with your ventilator valves or functioning. So I appreciate you sending it. This one has stumped several people here, but I could not call this volume control as it stands. Alrighty. Yes, Pink. The mode is volume control ventilation. It says down here.
VCV. It says right on the screen.
Right. And so Ivor just sent us the PDF with the for the ventilator.
Cool. Thank you.
Yeah. So this is the GE one, right?
Yeah, it's not readily available to us, but it's just they're using the angstrom name as a marketing thing.
Okay, so that's why I said the GE, the CareScape that we have now was the upgraded angstrom care station, which is what you're showing here. Yeah, so there's something drastically wrong with this ventilator. It's not operating according to the manual.
That's good. Well, so that actually, if anything, this should point out that this is totally abnormal, and we probably would be suggesting. I mean, we rarely change ventilators on patients just because of something, but this doesn't look normal, Satish. So thank you for submitting that. All righty. Woo! Tough one. Any comments about the last one, Ivor? Since I'll take the benefit of you being here. Any comments?
I understand the issue about an ultrasonic nebulizer usually showing an oscillation throughout the cycle, but you will recall that you can trigger these things just off the inspiratory cycle.
Oh, yeah.
So I'm still need to be convinced in a pediatric patient, if this is what it is, that they weren't running an ultrasonic in parallel.
Yeah.
Triggering it off the inspiratory flow.
Something was really, I mean, it's 425 tidal volume that's getting only 98 according to this thing. So something is amiss over here.
And it's going at about, I don't know, 6 hertz or something like that. It's really a very high frequency oscillation.
Very high. All right. Well, thank you, Satish, for stumping us. Appreciate it. Thank you. Next one. This one is also fresh out of the screen of a patient. So any fellow wants to read this one? That is not in a cafe. Or anybody. I have no problem. Have no fear. Alrighty. Well, let's give it a. I'll read it with all of you together, and we'll go through it. So, what is the tag? And remember, that's we're trying to describe. Obviously, you can see on top here the brand name, which says Auto Mode PRVC volume support. And as we have said, that doesn't necessarily tell us much about what the mode does. What this actually stands for is that this is a mode that has, it's an IMB mode, so it's pressure control. So the variable that we're controlling is pressure during the breath. And even though you can see beautiful, every single one of these flow waveforms looks identical, this is not a geometric figure. That's the way that you recognize. Usually it's a square or a triangle or a sinusoidal. That's one of the ways to recognize if this is volume controlled. So we are controlling the pressure in this case. And we know this because we have classified this mode that this is actually IMB, and the type of IMB is type 2. And we're going to talk about this in 1 second. And then the targeting, so the programming of the ventilator is actually A, so adaptive. So let's just go a little bit more into depth here. So the pressure is being controlled, and IMB means intermittent mandatory ventilation, and that means that there are mandatory breaths or spontaneous breaths that coexist together in the same breath sequence. So there can be mandatory breaths, and here we only see spontaneous. So you can see that this is pressure triggered and is cycled by the patient, because even though here it would be a little bit hard because you cannot see anything and all of them are very regular. In this situation, actually the ventilator is highlighting that it's in, you see this is whitish, so it tells you that it's in volume support. So we know that that's a spontaneous breath. Each one of them is cycled by the patient. Type 2 comes from a classification in which Rob has worked a fair amount to distinguish what actually the different types of IMB are. And I would just say that a common concept is that IMB was a bad mode in general for patients that are on mechanical ventilation, but that type of IMB that has been described on those articles, and we fully endorse what that came from those articles, is type 1 IMB, which is the most primitive type of IMB, and essentially it means that actually, Rob, since you have worked a lot on this, why don't you explain what each one of the modes, the types are, and I'll write them as you explain.
Okay.
Is that fair?
The original IMV type 1 was designed so that you can set a frequency for the mandatory breaths, and you will always get them regardless of what the patient does. But the patient can also put as many spontaneous breaths as they want in between the mandatory breaths. And it was, as you say, it was shown to, well, it was originally designed to be a weaning technique, but it was shown to actually prolong weaning because it takes people a long time to daily or every time they go to rounds to decrease the IMV rate and let the spontaneous rate take over for the patient. IMV type 2, like we see here, is an adaptation such that if the patient's spontaneous rate is higher than the set rate for the mandatory breaths, then the mandatory breaths will be suppressed. And the patient essentially then is just in pressure support as they are in this case, although in this case it's adaptive targeting, so it's volume support. Now the problem with this, I mean, the advantage of this is that you don't get the mandatory breaths causing synchrony problems, and you don't have to come back manually and decrease the mandatory rate. The patient essentially weans themselves in that respect. The problem is, though, that the patient could just be taking a lot of small, shallow breaths and just ventilating dead space. So type 3 says, well, it's not just the spontaneous breath rate that will suppress mandatory breaths, but you have to have the spontaneous minute ventilation. So now it's taking account of the tidal volume as well as the spontaneous rate. So if the spontaneous minute ventilation is higher than that mandatory minute ventilation, then again, mandatory breaths will be suppressed. And then the fourth kind is that if we have dual targeting, dual targeting where the patient can turn a mandatory breath into a spontaneous breath by taking a large enough inspiratory effort. In other words, it goes from a volume cycled mandatory breath to a flow cycled spontaneous breath, like you can on some of these ventilators, like on this one in particular. Then you have essentially suppressed an individual mandatory breath and replaced it with a spontaneous breath. And so there again, you're back into a type of IMV, and that's type 4 IMV.
Thank you, Rob. I would highlight that this type 2, obviously, like any mode of mechanical ventilation, can be implemented the algorithm in different ways. So for this mode, auto mode, the spontaneous rate will suppress the mandatory. And then there's a setting, and I'm still not entirely clear about this, there's a setting in which called the apnea time. And when you reach that amount of time of apnea, then it starts triggering the mandatory breaths. So it's not necessarily the rate that you set over here, that if the patient breathes under it, it has to do a combination of or some other triggers that have to do with the apnea time that you set on the settings for auto mode. And finally, there's the adaptive targeting, and what that means is that we set a target tidal volume. You see it here, and this tidal volume, if the patient is meeting it because of the compliance is better, or because the resistance is decreased, or because the PMOS is active, like in this case, then it will continue to drop the pressure to achieve that tidal volume. And so you can see actually on this circumstance that the patient actually inhaled 721 milliliters. And so the machine is essentially not giving any support right now. The patient is breathing on CPAP, on a PEEP of 16 on its own, with no support, because the machine will decrease the pressure so that you can keep at the target. And if the patient gets paralyzed or sedated at some point, and the PMOS decreases or the compliance worsens, for the ARDS gets worse, the machine is going to start going up and up and up on the inspiratory pressure to achieve that. This mode, or when you use this algorithm, it may be good for patients that were sedated and you're waking them up, and that way you don't have to be going and changing from one mode to the other one. Alrighty, I see a question. In type 1 and type 2, the processor sets a window for the sensing time epoch, that is the opportunity window for the BE detection in 3 and 4. Yes, so there's definitely, so there's for type 1, there's a synchrony window. There's no question about that, so that it synchronizes with the patient effort, but they will still deliver the breath. There will always be a mandatory baseline rate. And for the type 2, I do think that there is a amount of time in which, if it doesn't detect, at least on this ventilator, on this iteration, it will trigger a mandatory breath after a certain amount of time. So yes, Ivor. And for 3, I actually depends, Robin. You can probably talk more about this, because it's the Draeger mandatory minute ventilation, right? It has to do with the spontaneous breathing, and then it combines mandatory breaths with spontaneous until you achieve your target goal.
Yeah, right. Obviously, there has to be some sort of running average for minute ventilation. I'm sure every ventilator does it a different way, and there's no way to know by looking at the manual. Although the Draeger manual is pretty good at describing the IMV, or mandatory minute ventilation in general. I'd have to look at it more carefully, but I don't know exactly what the trigger is that says, okay, now you haven't met the mandatory minute ventilation target for such a period of time, and now we'll deliver mandatory breath. But for type 4, it switches from a mandatory to a spontaneous breath whenever the patient, basically you can think of it as their neural inspiratory time is longer than the set inspiratory time. So the ventilator can't shut off because it's already in pressure control, and the patient, and when it goes into pressure control and it's exceeded the tidal volume setting, then it becomes flow cycle. It just becomes a pressure support breath. It actually says that in the manual.
Fabulous. So really good review of the different types of IMV. They're all over the place. I mean, it's amazing that the modes now that contain IMV throughout our ventilators. So what is the load? The load is actually during inspiration is PMOS. I mean, as you know, this should actually look like a descending ramp. So if it's not looking at ascending ramp, everything that it's above that is PMOS. So throughout inspiration, there's PMOS, and similar to the first case that Stephen described, this looks like there's active PMOS also during exhalation. And actually, just an observation of this PMOS and how the pressure has essentially been zero now. So all the effort is being generated by the patient. Is this other feature that sometimes drives me nuts, that you come to the bedside and tell you, oh, the compliance improved, and you see this compliance over here, and I mean, that's the horse compliance. I mean, it's wonderful compliance, right? Huge, 146. But this is all an artifact of the PMOS delivering that tidal volume and affecting the calculation. So don't be fooled by that number. In terms of trigger, I think actually the trigger is pretty decent. It triggers and it doesn't go below the baseline. So I would actually call it normal. I would wait for any tomatoes flying my way, but I think that it's actually triggering appropriately. But there is a fair amount of work shifting. It doesn't drop below the baseline, but this patient is doing all the work. And so in this case, it's only patient, no machine doing the effort. And then the cycle seems to be appropriate, actually, because it's volume support. The patient actually is relaxing his muscles and transitioning rapidly into active exhalation. So this drop, you can see there's no pause on the flow at all because it's a spontaneous cycle. So this that you see here is an artifact of just the speed with which the pressure is dropping, the flow is dropping. The ventilator cannot maintain the pressure where it wants to at zero, and so it goes up. So it's just an artifact. So it's not a late cycle as I used to think before. So this would be normal. And then finally, as we said, expiration, the work is, there is work of breathing at exhalation. So in this case, you can imagine as you're walking by, I'm gonna just ask this question to the group. If your goal is safety, meaning you're trying to avoid ventilator-induced lung injury, and you're trying to maintain your gas exchange, is this mode achieving the goal? And I would say, I mean, the tidal volume right now is 721. It says here that it's 6.7 cc's per kilo. But the patient is doing all the effort right now. So we could argue that essentially he's on mechanical ventilation with no support, and there could be diaphragm injury or else. Besides, he's on a very high PEEP, and all the effort is being generated by him. So even though the peak pressure may not look, or the pressure may not look very high, it's possible that the patient is generating more transpulmonary pressures in certain regions of his lungs. That could be an issue. So I would pose that, especially now in these days of PCLI being again on our radars, that the patient is likely to be on that we could potentially do something different with this. Now, there's no mode, and I will actually pose this to the audience. Is there any mode that can achieve this in a patient like this without sedation? And I don't know. Is there any mode that can achieve this in a patient, keeping him with this amount of spontaneous breathing and achieve the goals of ventilator-induced lung preventing BLE? I think not. It's probably impossible to maintain this amount of work of breathing. And if I put him on volume control, he would be against this. So somebody asked. So yeah. So good question. So there's one item here from Tim Howell. Why would you have someone in auto mode with 65% and 16 of PEEP? That's a great question, Tim. So as this patient, and actually I can talk about him. I took this picture before we did an action. The patient was on PRBC, and the day before we had stopped paralytics, and he became desynchronous, leading to more issues. As you can imagine, more sedation, hypoxia, and whatnot. He was working against the ventilator and whatnot. So we said, okay, let's put him on volume support. He was on PRVC with the same settings. He's a fairly large individual, as you can probably see by the tidal volume that he's set at. And then we turned off the sedation for his spontaneous awakening trial, and this was the result of that. So he had his spontaneous awakening trial. He was synchronous, but he was not protecting his lung. So that led to changes on where we are.
I have a question about that.
Yeah.
Why would you think that auto mode would not be indicated just because someone is sick?
No, I guess that the question was why would we let him breathe spontaneously at higher peeps? Probably that's the question. I don't know. Our team, if you want to clarify there, that would be useful. I will ask us by level in patients with very high respiratory drive, would that achieve the goals of preventing ventilator-induced lung injury? I presume, I mean, if you go very high to total lung capacity and don't let them take larger tidal volumes, right? So you have them at the highest, that's so that the diaphragm is in a disadvantageous position to not generate enough larger tidal volumes. That's a potential, as long as they don't generate very large diaphragmatic excursions and transpulmonary pressures on the high P on the P high. I presume that would be, and that's a way to decrease the tidal excursion of the diaphragm, just going really high up, and as long as they stay synchronous with it, if they can stay synchronous with it.
Almost to the point of APRV mode, if you push the bilevel with a very long T high, what it allows you to do is to cause diaphragmatic displacement and hold it at a mechanical disadvantage. They may get mild cycling and then drop down for a short T expiratory is one strategy.
Yeah. We have struggled so much. I don't know what your experience is with it. I were on finding a good way to set up bi-level at high levels and have them synchronous or achieving our goals of Billy with these patients. But we're open to learn. So if you let us know, but definitely I do agree with you. If you push all the way up and the diaphragms cannot move, then that will limit the excursion of the lungs and achieve recruitment, as long as the patient doesn't do any effort. Very good. Rob, any concerns, thoughts?
Yeah, the problem with APRV is that depending on how you use it, if you set a desired PEEP in APRV, that's one thing. But if you're trying to set PEEP with gas trapping in very short expiratory times, there are two major problems. One is that many ventilators won't let you do it. You think you're setting a short, like 0.5 second expiratory time, but they won't actually do it because they have internal safety overrides, and that destroys the PEEP you think you got in the lungs. And the second is that patients with sick lungs have a non-homogeneous distribution of time constants. So every area of the lung that has a different time constant is going to have a different PEEP. And generally, PEEP goes to the more compliant areas and not to the sick areas where you want it to go. So trying to rely on gas trapping to deliver PEEP is not a sound strategy in my mind.
It's actually, you just triggered, we should do an APRV special. How about that? That would be cool. We can do some synchrony issues and just analyze the curves on somebody on a couple of or 3 patients on APRV or TCAB, and see how that looks. Thank you for bringing that. We have not done that, so that's pretty cool. Alrighty. For those of you, thank you very much for attending. For the CCF physicians, here's the CME code. We're working endlessly to make this actually available for everybody. So just scan the code, and there's the CME code that you enter, and that will give you CMEs. And again, send us your waveforms. So we as you can see, there's quite a bit to learn from each one of these waveforms, and the discussion is amazing. Ivor, I have to. This is such a pleasant surprise to have you visit us at VentRounds. Thank you very much, and great time over there in Denver.
It's an honor. I really appreciate the privilege to join you. Thank you.
All right. Thank you, everybody. Have a great day.